welcome to another month for the EM Critical Care Medicine section for AAEM. This month, there's recently a really big trial came out, the device trial, which I think asks a question that we all have been wanting to see a well-studied, large randomized control trial that may or may not kind of confirm some of our previously held beliefs. So with that, let's break down the device trial, and we'll talk about kind of what we think. So Shadman, do you want to talk about the trial?
Yeah, so the device trial, it was looking at video laryngoscopy versus direct laryngoscopy and seeing if video laryngoscopy could secure an airway on the first attempt, mostly critically ill patients. So they ended up doing a multi-centered, unblinded, randomized trial where they went through 17 sites consisting of multiple ERs and ICUs. All the patients were older than 18, with their median age of being around 55. Most of their intubations were indicated for altered mental status or acute respiratory failure. They excluded pregnant patients, prisoners, and then people who needed to be intubated right away and couldn't go through the randomization process. So they ended up having 705 patients do the video laryngoscopy, and then 712 do the direct laryngoscopy. They ended up removing 3 at the end of the trial because they were found to be prisoners. And then with that said, Ava wants to talk about the outcomes.
Sure. Like Shadman said, the primary outcome was first attempt success rate, and the secondary outcomes were actually a bunch, looking at complications mostly, such as hypoxemia, severe hypoxemia less than 80%, severe hypotension, any cardiac arrest that did not end in death, and cardiac arrest that did end in death, which I would consider complications. With the primary outcomes, it was actually amazing. For video laryngoscopy, 600 out of the 705 were successful on the first pass, while direct had 504 out of the 712 successful on the first pass. So that's an 85.1% success rate versus a 70.8% success rate, which kind of went ahead and just confirmed what the general population was thinking in regards to this. But yeah, that was kind of how I saw it.
Alex, you're a senior resident, so soon you're going to be in a position of breaking down trials for other people, for your learners. What did you think about this trial, and has it changed anything for you?
So during my time in residency, we've had numerous conversations with Strayer and other kind of airway experts, and he just believes that if you can get a better view with VL, why would you ever DL? And that's kind of his perspective of you have the ability to get a view that you otherwise cannot obtain with DL. And so if VL is available, that should always be your go-to. So this kind of more or less just kind of confirmed that belief. Go ahead, David.
I was going to say, and that's kind of exactly what they found, right? The things that led to making the intubation, or that made people not succeed with DL as compared to VL, was not necessarily the ability to pass the chords, right? But it was a pretty big difference in the ability to see the chords, which I think confirms exactly what Ruben Strayer might say, which is you have to see the chords to intubate, although you can be really sneaky about it with a couple other tools. That's probably not what we'd want to depend on.
Absolutely. And No, but we still have this like other belief that you should still continue to practice and be good at DL just for the sake of you will, wind up in situations where your VL device fails you, which has, happened. And especially in my training, when I have like a opportunity to DL and to kind of get better at that, I think that is like one of my personal goals in this last year of residency.
Allie, what are your thoughts?
Yeah, I mean, I didn't actually get a chance to read this specific article, but usually when I read like these airway articles, my experience has been that they usually study it in a patient population or a clinician population that might not be experienced. And so like my experience has usually been that those that are experienced, there's not really much of a difference between direct and video. However, with that being said, and I think this makes sense for the inexperienced group because the video automatically gets you a better view. Some will argue that you can't always, like in situations where there's a very contaminated airway, it can be sometimes difficult depending on what video scope you have to do or to maneuver everything with like the suction devices and the blades and then the screen can fog. And so some may sit there and say that you should kind of beef up all the tools in your toolbox and get comfortable with both.
So I will add that they've actually studied whether or not VL is reliable in a soiled airway as compared to DL. And they actually found that VL was, even in that case, was at least as reliable as a DL airway. And for those of you who aren't familiar with the salad technique, which I actually used recently to inspect an airway, it can be really handy to kind of keep all of keep your camera pretty clean during an intubation. And they actually looked at, the effective experience on success with VL or DL in this trial as well. So I think they did a pretty powerful job of asking that. Elias, does this change what you do in your practice besides what the cardiac surgeons want?
Well, during training and also in fellowship, I also tend to favor VL. Just it's a good tool to have, and especially as attending, if you can see what your residents are doing, that's helpful. Even if they're using like a CMAC with a DL capability, at least you can teach them easier. So it has the additional capability of educating someone instead of like back in the olden days when you do DL and you're just yelling like, what do you see? What do you see? Do you see chords or like, what's next? Where's the epiglottis? And it's like, and then you don't even know what they're doing. So it has a good kind of tool for educating techniques when you're trying to translate that. I tend to favor VL as well, just because if we have a better optimization, why not? I'll use DL if I don't have it, but if I have VL available, I usually tend to grab it, even as just having it there.
I think one of the big things about this study that is important to note is a couple things. One, this trial ended early, and anytime a trial ends early, you need to be, I think that we should be suspicious of the findings, especially when we see findings that are this discordant with what we have from prior studies, even if this is something that kind of confirms what I think a lot of us have felt. I think one of the other things that's important to note is probably even more important than first pass success, which is first pass success without any major adverse effects. Still favored VL, but that was entirely powered by the ability of VL to get first pass success, and not necessarily VL preventing harm, but by VL getting first pass success and getting the tube through the cords, which is also important. One of the other really big weaknesses of this study is, if you want to be a real purist, they only use the hyperangulated blade in 14% of the VL cases. And I think if you're a purist about it, you could say, well, you know, hyperangulated video laryngoscopy is an entirely different tool, right, than standard geometry video laryngoscopy. And so, you know, we don't really know what effect that may have had on the results either. And I think those are all really important points to make when we think about breaking down, or several points to make when we talk about breaking down this study. I did see some people make a lot of comments about the study had pretty high rates of complications. So whenever we talk about a study, you have to put it into the context of what are the first pass success and what are the complication rates that we see from other studies. So I went and I looked back at the Intube study, which had complication rates that were actually higher than this study, almost in the 40s. And they had a pretty high rate of direct laryngoscopy in about the 70s. And when you compare that to the Bougie trial, which is a study where everyone was intubated with video laryngoscopy in a Bougie, they had complication rates closer to the to like 10-11%. So I think, again, this may all point to the idea when we look at it in context. Do you want to give us your thoughts? It's a lot of experience in this.
I'm not sure if you could hear me. You were doing the freezing thing. Can people hear me?
Yeah.
Okay, awesome. Thanks. I think you asked for my opinion. I'll assume so. I don't know if it's David's side. Yeah, so let me first put out a disclaimer. I did critical care anesthesia before I went into emergency medicine. I did this many moons ago, so I have a very different perspective. DL was all we had back then. That is clearly what I made my mark on. That said, I'm an academic. I get it. The value of VL is equivalent to driving an automatic. As much as I tried to teach my kids how to drive a stick, an automatic is just easier, right? And you're going to get to the same place. And listen, even Porsche gets it. The best Porsche is an automatic now over a stick. So to that end, I think the study does confirm what we kind of are already thinking and know. I do have a question, though. I'm an old fogey, and I wonder, I was in New York City. I was in Mount Sinai during COVID. And, with my residents, I'm the difficult airway guy. So when everyone misses, I'm the guy they call. And I 99% of the time would always do DL and usually get it with DL, knocking on wood. That said, 99.9% of my residents, even pre and post COVID, they do VL. That's just, I think, the mark of the times. And so I wonder if this study noted for the age of the intubator. I believe Ali brought up the fellow resident level of most of the intubators. I'm just curious if a study comparing, like VL, DL, not only in the younger trainee population, but in my age, the 50, 60-year-old guys, like, is it equal? That'd be an interesting thing for me to know. But anyhow, I did like it.
So they actually did bring up in the trial, they did stratify by number of prior intubations with video laryngoscope. And so they broke it down into less than 25%, 25% to 75%, or greater than 75%. And that was split pretty equally between the two groups. And when they looked at whether or not those were, when they stratified it by prior intubation with first off, when they stratified it by prior intubations, it it started to move towards equal between the groups. And for people with more than 100 intubations, there was no difference, right? Which isn't entirely surprising, because once you're familiar with the tool, the movements, right, the micro skills are essentially the same as long as you can line up your eye level, which is probably the biggest difference and most challenging part between the two. And when they also looked at proportions of previous intubations with a video laryngoscope, right, the more prior intubations you had with a video laryngoscope, the better you did, the more it favored the video laryngoscope. So I think that says if you're really comfortable with a video laryngoscope, you're better with the video laryngoscope. And if you have lots of intubation experience that may not be with a video laryngoscope, it probably is more equivalent between the two. I have a suspicion, just anecdotally, that if you have lots of experience with direct laryngoscopy, that you would have problems with video laryngoscopy. But if your only experience is with video laryngoscopy, it may be a difficult transition to get to direct laryngoscopy, is my suspicion. But that raises the question, for most of us, is there necessarily, is there a purpose to still learning direct laryngoscopy? You would probably say yes, based on your experience, but for the rest of us that are attendings,
I would still say yes, because the video doesn't always work. Sometimes it runs out of battery, sometimes it fails, sometimes the plugin disappears. You have many kind of, and especially for the hyperangulated blade, sometimes you lose the trocar. So that kind of changes the dynamic in how you angle your stylet to try to manipulate the same kind of angle. So there's a lot of factors that sometimes being proficient in both might save you when one fails you and the other doesn't, just like what Alex says. And what you said is kind of confirms in one of the previous studies as well. And Al probably kind of agrees on that kind of is if you're proficient on whatever skill set, when you get to that mastery level, it probably doesn't matter what tool you use, as long as you're using the tool you're most familiar with. And all the studies beforehand show similar things. Once people have intubated multiple times, the difference between video and direct kind of disappear. And that kind of lends to the idea of mastering something, whether it's driving stick or driving automatic or anything like that. Once you master it, the difference becomes less. But when you're learning, something easier to pick up is probably easy for an early learner, but that kind of goes back to the same kind of trope as educating. It's an easier tool to pick up is always easier to learn, but once you get mastery, it probably doesn't matter as much.
All right. I think that's as good a summary as we're going to get. Anyone else have any final thoughts?
Just one thing for the course we put on. The first year we did the practical session was mostly DL. And the second year was VL with some DL. And the students had a higher pass rate, a higher success rate with the VL than they did on the DLs. It was just something we saw in the course, but it's not an actual published study yet.
All right. Cool. Anyone else? Awesome. Thanks, guys, for a good discussion.
Thank you.